Okay, we're going to get started now. Thank you. First of all, greetings to everybody, and thank you for joining us. And welcome to the IFAM seminar series, which is today presented in partnership with the Buehler Center for Health Policy and Economics. I want to take this moment to also welcome our online viewers. Please be aware that we will not be monitoring the chat during the seminar. If you have questions for the speaker, please use the Q&A function, and we'll do our best to answer those at the end of the talk if time permits. So it is my great privilege to introduce Dr. Dan Ciccarone, or Ciccarone, however you want to say, sorry. He's the Justine Minor Professor in Addiction Medicine in the Department of Family and Community Medicine at UCSF. He's been the principal or co-investigator on numerous NIH-sponsored public health research projects, including his current synthetics and combination study. He is recognized internationally. He's an internationally recognized scholar on medical, public health, and public policy dimensions of substance use, risk, and consequences. He consults for numerous private and public entities, including the Office of National Drug Control Policy, U.S. Centers for Disease Control and Prevention, and the U.S. Food and Drug Administration. For over 20 years, Dr. Dan has been actively involved in expanding the use of clinical harm reduction technologies and services, for example, naloxone, buprenorphine, and drug checking. He has provided harm reduction-based clinical services at several San Francisco syringe exchanges and is currently the volunteer medical director of Remedy Alliance, the U.S.'s largest not-for-profit wholesale distributor of naloxone. And with that, I'll turn it over to Dan. Thank you.
Thank you, Lori. And thanks so much for the invitation. It's a real pleasure, a real privilege, honor to be here today. I think all of you, I'm taking it personally that you all are afraid of me in the back row. But, you know, I'm not going to, I'll let it go. And it's also great to be in Chicago. Like, I love this city. I've been here a lot. I helped get the first drug checking machine up and running here with my dear friend, departed Dan Big. But I'll tell you, as a New Yorker, your concept of pizza is a little bit off. Okay, I know, let's start with some controversy. That's okay. But let's talk about fentanyl. Thanks for all coming today. It's a harsh talk because fentanyl is a harsh drug. It's been with us way too long. It's killed way too many people. And I want to sort of do that technique in science fiction where you take current trends and extrapolate into the near future. So I'm not going to go far afield, but I want to talk about the past, the present, and then bring us a little bit into the future about where I think fentanyl is unfortunately going. Some declarations of interest, including the one that Lori mentioned on Remedy Alliance. We are the nation's largest wholesale buyers club of naloxone. We're trying to bring the price down and distribute it as widely as possible. Here are the learning objectives. I'll let you read them later. I assume we'll distribute the talk. So this comes out of 2 NIH grants, about 13 years of experience. The current one is synthetics in combination. What I'd like to do, what I've done over those 13 years, and even longer, maybe probably about 20 years, is create this multi-methodological dialogue where we all know the benefits of epidemiology. Gives us nice breadth, gives us reproducibility, it tells us the who and the where, gives us time trends, but it's limited in causal inference. And we all know those challenges of making causal inference, right? One of the challenges is plausibility. Do we understand risk well? Because if you don't understand the risk well, you're not going to have a very good predictor for your study, or you'll come up with false or as Paul Farmer would put it, immodest causality. So I bring an ethnographic model to give us depth. Now, it's not very reproducible, it's not very generalizable, but if done right, will give us context, it'll give us depth, it'll help us give social plausibility to our epidemiological models, it'll give us the why, which really eludes us in epidemiology. So I mean, that's all you're going to get about theory and methods, and we'll move on. So why are we here today? Well, here's a graph of US mortality. We have two peaks 100 years apart based on viruses that went pandemic, the so-called Spanish flu, and then COVID-19. But along the way, we've had what we expected, what we hoped for, and that is a decline in mortality over time due to advances in public health, advances in medicine, improved aspects of society. But recently, we've had a reversal of fortune, right? And this is due to drug overdose, right? This increase in drug mortality was so big among a small population that it affected the life expectancy and the death rate of the larger population. And that's what we're going to talk about today. This is coming multiple waves. The original model was a 3-wave overdose epidemic. This is now lingua franca. I coined this term. And what it stands for is that there are 3 ways of subclasses of opioids that have caused mortality in America. The first one, as we know, was due to prescription products that were widely diverted and misused and caused, you see that blue line, steady increase in overdoses. That's sort of tapering off at the end. But as we pulled back on the opioids forcefully, we begat a historically large cohort of heroin users, the likes of which we've never seen. That use of a more powerful drug, and also a more inconsistent drug, right? Purities go up and down, led to the second wave of overdose. And now we have heroin, which is being adulterated with or substituted by synthetic opioids, the main which is fentanyl. For the rest of the talk, I'm going to talk about fentanyl. What I mean by that is I basically mean all the synthetic opioids other than methadone, but mostly we're talking about fentanyl. We haven't seen the end of this spike yet, this attack curve, right? Keeps growing. And now there's a 4th wave of mortality due to psychostimulants and cocaine. By psychostimulant, I mean methamphetamine. I'm just going to use methamphetamine for the rest of the talk, leading to those 2 bottom lines there. 4th wave of mortality. A lot of this is co-occurring with fentanyl. I'm going to break that down a little bit in a minute. I'm a supply side expert. I understand supply is a problem in drug use cycles, right? In fact, I think it is the biggest problem. Let me just show you what's gone on in 100 years of understanding opioids, right? The first opioid epidemic started with illicit products, morphine and heroin, as they were developed, right? They weren't very regulated. Pharmacists doctors could prescribe them, or pharmacists could just dispense them as needed. This was a novel drug. It was iatrogenic for the reasons I just said. And there was a technological advance. Anyone want to tell me what the technological advance was at the time that led to misuse and harm? The invention of the hypodermic syringe. This was an upper middle class drug. It was not, what we think of heroin today. But then we said, oh, it's a problem, so we're going to make it go underground. Well, that led to heroin wave 2, which was underground. What happened when it went underground in the 1919s and the 1920s? It switched demographics. It went poorer and it went to minority. There's been some cultural waves along the way, but then we get to the Vietnam era, the 60s and 70s, and the Colombian era, where Colombian heroin took over heroin in the United States. New source, right? Which means new supply, new product. And you want to compete with a product, whether it's illicit market or illicit market, you bring something that's better quality at lower price. And that's what the Colombian cartels did, took over the heroin market in the East Coast of the United States. And now we get to the triple wave. We have opioid pills again, recurrent theme of iatrogenic source, novel form, technological advancement. What was it? The ERLAs, the extended release long acting. People found the pills relatively easy to crush and snort or inject. And then heroin and synthetics, again, new source forms, novel. If fentanyl didn't come along, we'd be in the midst of a heroin epidemic right now. Fentanyl has just sort of overswept it. There's the triple wave. Okay, I'm just going to go through each wave one at a time, looking at supply. Here's opioid prescriptions, and here's overdose on the right. Right? Interesting how they match up so well. In fact, it's so well that we thought that in 2014, or 2013 really, that we got a handle on the problem. Unfortunately, as I just showed you, wave 2 heroin started to peak around this time. Why? because a lot of people transitioned from opioid pills, right? The diversion thing was so huge, it created a vast street network of cheap product that was widely used. And then when we pull those away, people started asking the same dealers, do you have any heroin? We documented this in 2 papers, one an epidemiological paper, Intertwined Epidemics, and one a qualitative paper, or ethnographic paper, Every Never Ever Said came true. Bottom line is that historic cohort of heroin users, this is a conservative estimate from the Rand Corporation, 2016, 2.3 million heroin users. Prior to this, people said, oh, we got 500,000, 2/3 of a million. This was like tripling or quadrupling the size of the population, right? I don't know any better way to start an epidemic than to expand the demographic, to expand the size of the denominator, right? And we did that. And it's also an under-recognized force right now. So when we think about why isn't buprenorphine working? Why isn't naloxone working as well as we wanted to? Why aren't some of these other policies that we've done working so well? It's because we're talking about a huge population. And you have a scale problem, right? There's not enough naloxone, there's not enough buprenorphine. So just to bring in a little bit of qualitative richness, Mary's a 51-year-old using heroin for 5 to 6 years, who was originally a patient, prescribed oxycodone. She says, well, like a lot of people, you start on the pills and the doctor gives you some more, and then you get cut off by the doctor. So every morning we would go to the dealer's house and they had both things. They were never out of heroin. But 3 times a week, they didn't have the pills. So I have to scramble around, and then I finally had enough and said, fuck, the hell with this. Give me a bag, and I was off to the races. Picture tells 1,000 words. This is from Philadelphia, an alleyway, pills to heroin transition. But now we're in the fentanyl wave, right? That's that gold line up there. Impressive attack curve over the last few years. Maybe a little bit of leveling off now. Lori and I were just talking about this. It's what's driving opioid-related overdose. That's what's driving overdose overall in America is fentanyl. What is it? It's a synthetic. It's lipophilic. It's so lipophilic that leads to high potency. It also has very high affinity for the mu receptor, again leading to high potency. This is mostly clandestinely produced, illicit fentanyl. It's not diverted pharmaceutical product. Initially sold a lot as heroin. It was such a powerful message that we got in our street work that we published a paper called Sold as Heroin, that people were buying heroin but getting fentanyl. And that, if you ever look at the Feinberg, actually work done in Chicago of set and setting, right? It really messed with people's idea of set and setting. And those are independent risk factors. If you don't understand the drug or the context in which you're taking it, it alone increases your risk of overdose, independent of the purity or potency of the drug. It is a very potent drug. And we have other examples of widespread adulterants contaminating products, for example, levamisole in cocaine. There are a lot of analogs. I can't keep track of the numbers. It's hundreds, potentially thousands of analogs, and they all have different potencies. In fact, the discrepancy is 4 log orders between the weakest fentanyl and the strongest fentanyl, at least 4, maybe 5. Here's one of the 4 or 5x ones, carfentanil, right? It's meant for elephants and large animals, not humans. It's way too strong. Where's the fentanyl coming from? Initially, a lot of it from China, as shown in this sort of cartoonish schematic from the DEA. I get a lot of my data from the DEA, but it just shows you that a lot of this is being manufactured and brought in either through the dark web or shipped through Mexico, mixed into heroin and brought north. Lately, a lot of the trade has switched to Mexico production. So precursors from China, production in Mexico, shipped north with the heroin. Initially, very much a regional problem. Here, industrial Midwest, down to Appalachia, over to the Mid-Atlantic, up to New England. This is changing, and I'll show you how in a minute. And I already said that fentanyl came in as a substitution and or adulteration. This graph gives us a nice depiction of both. Adulteration, this is heroin plus fentanyl, is the orange line, and blue line is these are drug seizure samples, seizures that only had fentanyl and they didn't have heroin. And we can see the blue line, the substitution, has been the strongest phenomena, but we can't ignore the orange either, that there has been this sort of unbeknownst use because it's hidden in the heroin. And this polarized preferences, right? People sometimes make a mistake that fentanyl is the new party drug, that people liked it, they told their friends. This is not ecstasy. You know, friends told their friends, and the next thing you know, you have a culture built around the new fun drug, right? Fentanyl is not a fun drug. A lot of people do not like it, did not like it. Now, today, if you say, you know, do you like fentanyl? They'll say, yeah, it's okay, you know. But what you really need to ask is, do you need the fentanyl, right? The dependency has been built up. The tolerance has been built up so high that heroin's not going to cut it anymore. So like it or not, that's what they use, or that's what they would prefer. But I love asking the question, okay, I got some fentanyl here, I got some reasonably good heroin, and I got a nice oxymorphone pill for you. Which would you choose? Everyone chooses the oxymorphone or the diacetylmorphine. Nobody wants fentanyl. So this is a supply-driven phenomenon. So Tim, who's age 45, using heroin for a long time, he goes, the high is wonderful. He's a high tolerance, right? Splendidly wonderful. It's magnified heroin feeling by a great number. But Rebecca, who's new to the scene, I don't like the feeling of it. I don't like the high of it. I don't like nothing about fentanyl. Heroin in this country has changed a lot. We used to exist when I first started doing research in heroin. We had the triptych here, right? You had black tar heroin, Mexican, went to the West Coast. You had this mythical white powdered heroin called China White from Southeast Asia, which was at once, you know, common in America, but it's been going away, replaced by the brown chunky stuff, reasonably good quality, pretty high purity Colombian heroin, not fully processed like that white powder, but more refined than the black tar, for example. That's going away. We see a lot of white powders now. This is photos taken in Baltimore. The cooker there has what they call scramble-based heroin, which is fentanyl. And just to compare this slightly off-white of that, we have a vial of brilliant white cocaine. We see a lot of grayish green. I'm comparing it with some paint chips here. Heroin across the heroin, which is probably blended of heroin and synthetic. Heroin typically cooks up as iced tea or light coffee, so famous that the Stranglers wrote a song about it called Golden Brown. But now we have this stuff. We have whites, we have bright yellows, we have clear, a lot of clear stuff. And these are fentanyl salts. Let's move to the fourth wave, right? The fourth wave means a lot of things to a lot of people. To me, I mostly wrote about number 2, which is in my paper called The Fourth Wave, the rise in stimulant and fentanyl co-use. But also the Western expansion can't be ignored, right? And fentanyl has moved beyond the Mississippi River. It's now on the West Coast and the Southwest. And we're not used to it. So deaths are going up. Just to show you a little bit of that, here's United States versus California opioid deaths overall. And you can see the United States went much quicker in this direction. California is starting to catch up. And it's being driven by synthetics. That's the orange line there. So this is no longer a regional problem. It's moving from that image to that, moving to the south in a big way, moving to Texas and the Southwest, moving up the West Coast. And if you look at drugs overall, this would now include deaths due to methamphetamine and the like. You see lots of places in brown. That's where year over year, 21 to 22, deaths have gone up. Interestingly, some of the places hardest hit by fentanyl, I see West Virginia there, I see Pennsylvania, starting to go down. So if there is a decline, it's an uneven decline, right? We've had a 3-fold increase in cocaine-related deaths. We've had a 18-fold increase in psychostimulant-related deaths. I sometimes give a talk just on that slide and starting with this slide. So I could go through each one of these in a lot of detail, but I'm basically just going to tell you that all of these are true. We've had increases in supply, increases in demand. On the increase in supply side, changes in production. We've never had a methamphetamine as pure and potent as the one we have now floating in American streets. But I will focus a little bit on the contamination question because it's a hot one about whether people are co-using or unintentionally co-using. through contamination. There's also been an increase in demand, but I'm going to focus on the co-use question. Here's data from the CDC suitors. Lori and I are working with developing this database. It's very exciting because it's a rich database. It's a good database to understand overdose deaths a little bit more deeply than just straight mortality data. Here's a paper from the CDC authors showing that of all overdoses, 33% involve stimulants plus opioids in combination, right? That's substantial. And of those, 80% are fentanyl related, and of those 80%, 2/3 are cocaine and fentanyl, 1/3 are methamphetamine and fentanyl. So let's talk a little bit about contamination. This is the unintentional co-use. I have access to a large database based in Ohio. I have 300,000 or more seized drug samples analyzed. What percent of the cocaine samples in 2020 had co-occurring fentanyl in them? Give me some guesses. Or maybe you know. 20%, great. Going once. Was that? 60%, all right. And the answer is, well, this is the database, 11.5%. So high, growing over time, but not as big as some people would think, right? And so a problem, but we'll see what happens next. I have a feeling it's going to continue to grow. And then the question comes about whether it's done intentionally or unintentionally. My rare talks with dealers is it's mostly just sloppy practice, and therefore unintentional. Methamphetamine, lower, 3.5%. Particularly if it's crystal methamphetamine, it's 0. There's been other drug checking studies that have shown 0. Sometimes when methamphetamine gets basically crushed into a powder form, there's a little bit of cross-contamination. But let's talk about demand, intentional co-use, right? We have to understand some terms here. The speedball is heroin and cocaine. This is multi-generational, traditional, well-liked, and it makes sense physiologically. The cocaine just boosts the heroin a little bit. So if you've been doing heroin for a while, you're starting to get some tolerance, cocaine makes it fun again, or at least interesting again, right? The goofball, historically very unusual, right? So when we started hearing stories about people mixing methamphetamine and fentanyl together, we were like, wow, that's interesting. Let's go do some field work. Because it's physiologically challenging. Usually the methamphetamine is so strong, even when it wasn't as strong as it is today, you just bowl out everything in front of it, right? It was just you wasted your money on the heroin. But the fact that people are combining it with fentanyl requires some explanation. So let's get a little explanation. If you want to hear more, we have a paper out. We have 2 papers out now on the goofball. Rebecca, she's in her 30s. She's relatively new injection. She prefers methamphetamine, but also like to inject both together. She goes, I mean, I prefer meth. I like heroin and stuff like that, but it's not my choice preference. But I do it every now and then. And actually mixing it with meth is the better buzz, believe it or not. And so she's talking about heroin, but this is fentanyl adulterated heroin. We're in West Virginia. We're looking at that neon yellow syringe. You know, it's fentanyl salt. But how do you decide on a given day? Well, just what we feel like. You know, how sick are we for heroin? How bad is the dope sickness? And if the dope sickness is not bad, we'll choose meth, because then you can fend off the dope sickness even more by being high on meth and you won't feel it. So there's a substitution effect going on. And we thought this was so interesting. One, we wrote a couple of qualitative papers on it, but then we made a model, an economics model, looking at the same Ohio drug supply database. And sure enough, as methamphetamine comes in, overdose is going down. Now, it's not a huge effect. It's a relatively subtle effect because methamphetamine alone is a dangerous drug and a lot of it's being co-used. But to some degree, it's acting as a substitute. So that's interesting. In summary, the 4th wave, we talked about contamination. I don't have any purity measurements, so I can't tell you whether it's meaningful, clinically meaningful contamination or not. Co-use is big. Co-use is happening. It's what's driving the 4th wave. I'll put a couple of nickels down on that. The fentanyl is strong enough to meet mono and mono with the methamphetamine, so you're creating a super speedball. Wide range of combinations and rationales. Read the Doxin paper. Robust supply may be driving this. Read the new Sarah Mars paper on this. Sorry, I didn't put the citations down on this. But adaptive responses are important too. People are using the methamphetamine to overcome some of the negatives of the fentanyl. They believe it's going to keep them from overdosing to some degree. They can get away from using it for a time or two. But we have to remember that fentanyl is a deadly element. I tell clinicians this, focus on buprenorphine because we're focusing on the fentanyl. But I also tell the harm reductionists this as well. It's not that methamphetamine doesn't cause problems. It does. But fentanyl is the deadlier one. All right, let's get to the fun part. What's coming up next? Let's talk about xylazine. Let's talk about counterfeit pills. Let's talk about smoking. I'm really invested in smoking issue right now. But let's talk about xylazine first, okay? Alpha-2 agonist causes sedation. So because it does, and it potentiates opioids, reduces withdrawal symptoms. So to that degree, might alone explain why it's partially substituting fentanyl at this point. Of course, most people are using both at the same time. It usually comes as a combo drug. It's causing a lot of abscesses, probably due to the peripheral vasoconstriction. But we do have a new theory on it that we're working on in terms of, in addition to vasoconstriction, something else. The wounds are bad, right? And this is not the worst of them. This is 5 out of 10. We've seen 10. Deaths have gone up. It's a regional thing, starting in that region 3 there, Pennsylvania and the like, but spreading. It's very interesting that it's spreading. Not a very likable drug too. So a lot more research needs to be done here. Pills. And if you want to know what the new risk factor we're looking for with xylazine and wounds, I'll tell you if it comes up as a question. So pills are another huge problem. Why? Because they're being used by different demographic, right? So we don't make a fentanyl containing pill. So any pill out there that's fentanyl containing is a counterfeit, right? This shows the volume of the counterfeit pills. This is a supply database we got through HIDTA, the high intensity drug trafficking folks. They finally, after 10 years of begging, gave us access to their database. And we see in this first graph here, in looking at the proportion between pill seizures and total seizures, that include pills and powder, we have a doubling over this time span. But even more impressive is the sheer number, okay? Fourth quarter of 2021, 2.5 million seized fentanyl pills. If we use a conservative estimate from the drug policy world of a 10% seizure to supply ratio, that means 25 million in that quarter. Annualize that, you have 100 million fentanyl pills. Anyone not concerned about that, right? And I can tell you with the latest data, it's quadrupled. Paper's not published yet, but I believe it's either tripled or quadrupled. So it keeps going up. And again, you have a different demographic. These are not necessarily going to people who have a daily, use of fentanyl and fentanyl tolerance. It's people who want a pill on the weekend, or a pill to study, or a pill to relax, right? Occasional users who think that Xanax tab is okay to use. But what if it has 1 milligram or 2 milligrams of fentanyl in it, right? They don't have the tolerance for it. So then you have the Joseph Friedman paper, New England Journal just came out showing adolescent deaths have gone up recently, probably because of this. Smoking is fascinating. Smoking is taking over the country. Let me show you why. So places where fentanyl is being sold as is, remember the whole sort of substituting, adulterating thing that's happened east of the Mississippi River. West of the Mississippi River, people call it fetty, or they call it fentanyl. It's not being sold as heroin, it's being sold as is. And where that's happening, smoking is taken off. The estimate I was using for a while was that 75% of injectors have switched over to smoking fentanyl. I believe the latest estimate is 90%, not published yet, but I heard the other day. Because it's that good. Heroin's not very bioavailable. Fentanyl salts are 97% bioavailable, highly tolerant of heat. The vaporization point is much lower than the pyrolysis, the destruction point. How are people doing it? There's a chunk of fentanyl in the middle there. It happens to be slightly blue, and there's some methamphetamine shards around it. Break off a chunk of that. They're using high heat, but not so high to destroy the drug. I'm smoking on foil often. Here you see all the apparatus, the lighter, the foil, the drug in the middle there, and the tutor or pipe to concentrate the smoke. Here you see the smoked fentanyl sort of in three phases: solid, liquid, and burnt. But people are also using super high torches and in silicon bongs to withstand the heat, titanium nails or bowls to hold the drug to withstand high heat, and they're flash vaporizing it, right? And the reason they're doing this is to mimic the bolus effect of the IV injection. So it gives us a mixed picture here. Like if you're doing that, well, then you're not going to reduce your overdose risk because the bolus effect is an important aspect of overdose, right? But if you're smoking, dab here, dab there, spread it out during the day, overdose risk should go down. So the question is, on the population level, smoking a benefit or not a benefit? Stay tuned. I don't have that data today, but stay tuned. I will tell you, though, that smoking is spreading. So you have 2,000 up there. This is the TEDS database, treatment database, showing low but relatively even levels of people being admitted for opioid and opioid dependency or whatever, and low levels of smoking. But now look at 2021. We certainly see the West Coast taking off, but all of those eastern states are all higher than 2,000. Some substantially higher in rates. 100th monkey theory: one monkey washes a banana at the beach, then teaches a friend, teaches another friend. All of a sudden, lots of people are washing the bananas, the sand off the bananas in the ocean. But I don't know. My prediction is it's going to take off as people teach each other that it's smokable. There may be some concerns that, I don't know, there's still a bit of heroin lying around. I don't want to burn it and destroy it and not use it. So we'll see. When we went looking we did some work around xylazine in Philadelphia. We were looking for people who smoke, and it was a little hard, a little challenging to find them. So what are the implications? I think it spreads. HIV has a positive one, right? Hepatitis C has a positive one. Overdose? Could argue it both ways. But to sum up, or begin my sum up, America's awash in pills and powders, injectables and smokables. This is actually from the south side of Chicago, this mural. So our policy implications and clinical implications are complex. This is a fourth wave. I'm actually starting to conceptualize what the fifth wave, looking at data, what the fifth wave means right now. It's a complex, intertwined. Those waves are not independent of each other. Intertwined, but each one gives momentum and whatever, raison to the next one. Driven by supply to some degree, followed by demand. It's certainly true for fentanyl lacing heroin and xylazine lacing fentanyl. People are not choosing the xylazine, in other words. It's evolving. New drugs, new combinations. There's a number of fentanyl plus combinations that are out there right now that need exploration. For example, we don't have a lot of fentanyl and benzo combinations here. We do in the counterfeit pills, but in Canada, it's a big problem. Teizolam and fentanyl in combination. Polysubstance use has always been the norm. It's always been a phenomenon. We've tended to ignore it because we like the headline drug of the moment, crack and opioid pills and fentanyl and stuff like that. But the reason why I say polysubstance use is the new norm is because the implications are higher. Mortality is high. The wounds with xylazine are huge. The fact that this has a continuing tsunami type effect needs to be problematized. I already said smoking is going to rise. There's some hopeful signs. Maybe we're starting to attenuate the death curve. But stay tuned. So far, a lot of this has been unpredictable, unpredicted, paradoxical. Again, we thought we were doing the right thing by pulling the pills out. Well, then heroin and fentanyl came along. So we need a crisis response. But unlike Keith Humphreys and Jonathan Calkin in the Atlantic, who said we need to re-stigmatize, no. They are dead wrong. Stigma is our biggest enemy here. People don't listen to us. They don't come in. They don't accept our care because they feel the shame and the stigma of the drug use. No, 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 no. We need to destigmatize. Everything we do needs to be bringing stigma down. Crisis response includes demand reduction and harm reduction and demand reduction. Sometimes I'm in certain audiences and I talk about supply reduction and people boo me. And sometimes I talk about harm reduction and I see all the police people in the back rolling their eyes. All hands on deck. We need everything for this. We know about demand reduction. We know about treatment, but we may not know that one of the theories in public policy related to substance use in America is that drugs fall into the cracks, right? And when are we going to get about fixing those cracks, right? Because otherwise the next epidemic, the next epidemic, the next epidemic will just fall into those. And of course we need harm reduction, which I'm a huge fan of. Here are some of the big policy advances that have happened. I'm proud to say that I've been involved in all three of these. Deregulation of buprenorphine, we're still waiting to see the fruit from that of Xing the X waiver. Naloxone and all means necessary. This has finally been adopted and accepted and funded and promoted. Still not up to scale. We still need to get scale. Maybe over the counter will help with that scaling. Maybe it won't, but things are rolling in the right direction. Harm reduction for the first time ever with Dr. Gupta and at the helm is a pillar of national drug control policy, and it needs to stay there. We need harm reduction. We know about some of the clinical challenges of fentanyls. The induction phase can be more challenging, but I understand from my experts on the East Coast, they figured it out. All right, they know how to do it. You know, in fact, the whole sort of microdosing inductions, you know, were invented because of this. You know, tease it in. But on the West Coast, of course, we're a little more cowboy. So Andrew Herring, he says we got to go a macro approach. You know, hit it hard on day one. Of course, he's in an emergency room setting, right? And so, you know, if it doesn't work, he's got IV ketamine and other ways to get around the precipitated withdrawal. But he's a big fan of big doses of buprenorphine. Why are we having this problem? It's still a relatively misunderstood phenomenon. It has to do with the fact that the drug is highly lipophilic. And it has to do with the fact that people move from acute use, right? I'm an anesthesiologist. I'm giving a pregnant woman in labor fentanyl. I want it to be short acting. I want it to be potent, but I want it to be short acting. I want to have control over it. And it is. You inject it once in a while, it stays short acting. Half an hour, 45 minutes. People use it chronically, it becomes a long acting drug. Lipophilicity, probably some lipodeposition, reduced renal clearance. Very important to understand, both for the clinical challenges, but also what it means, you know, writ large in public health. It's a long acting drug when used chronically. I love seeing naloxone in the field in any form necessary. This is harm reduction. I could talk again another hour on harm reduction, but let's just talk about the avant-garde of harm reduction. Chicago, first spectrometer, Fourier transformed infrared spectrometer fitter in the country legally here in this city. This technology is taking off, right? Everybody wants one of these $60,000 machines now, and they're all teaching each other. There's a consultation group that helps the new people coming in. They exchange libraries because the machines have to have a library to understand what the spectra are of the chemicals. It's extraordinary to watch. And I'm proud to have been part of that early phase, particularly here in Chicago. But we also have test strips, immunoassay test strips, high sensitivity, which is their bonus point. The spectrometry has a minimum detection of 5%. So a lot of drug checking programs are doing both. High sensitive, immunoassay, more specific, the spectrometry. I've never seen a harm reduction approach take off as quickly, right? It was underground for a minute and then it took off. Now, what are the implications of it? Not quite clear yet. Not quite clear whether the empowerment and educational aspect to the consumer is going to lead to risk reduction. Stay tuned. Just some pictures of that. Here's the immunoassay, the fentanyl test strip. Here's the alpha Brucker spectrometer. In fact, this photo was taken. This is the first machine. This is taken in Chicago. There's also messages we're not making these messages up. They were organic messages that people are telling each other and sharing about going from high potency shots, very dense, very high volume, high concentration shots, to smaller shots, less concentrated, to putting some up their nose to taste it. This tastes more synthetic-y than heroin. I know what heroin tastes like. Let me not inject it. Let me just snort it, or let me inject a small amount. Injecting slowly, tasting the drug, whether it's through the nose or a small injection is also called the taste. This is such an important phenomenon that Be More Power in Baltimore, a wonderful harm reduction group, said actually made a campaign of it. Go slow, fentanyl is here. And with that, I'm going to end because I'd love to have some time for questions. This is my study team. We're in Huntington, West Virginia, and in this photo, but I just love my team. I'm very proud of them. And of course, I want to thank the participants. I want to thank the funder, NIH, and I want to thank all of you here and remotely for your kind attention today. Thank you so much.
All right, thanks everybody. If anybody has any questions, we have 2 mics. We'll run around the room. Start right up here.
Thank you for your talk. I am old enough to remember when fentanyl came into pharmaceutical use in the 80s, and at the time in anesthesia, it was a real benefit because it was finally a cardiovascularly clean narcotic, and it actually, I think, revolutionized the way anesthesia was administered. But that was the 80s, and yet this fentanyl epidemic in the general population from non-official sources only started in the 2000s. So what happened? Were there changes in China? Why did it take so long, and what happened to ramp it up? Why did it happen then? I mean, I understand from what you said, the sources of the raw ingredients, China, it's made in Mexico, a lot of it, and comes through but a lot also obviously comes from the airports if it's on the East Coast. So is there something that happened in China? I mean,
yeah, so it's a really good question. The why fentanyl question is still unanswered. If we had 100 drug policy experts here, I have my favorite theory, and many of them would shoot spitballs at me because they don't like my answer. My answer is that the number of heroin users shot up so quickly that the Mexican cartels couldn't make enough heroin. And they brought in fentanyl as a substitute, and they brought it in to the turf that they had recently acquired. Again, if we didn't have fentanyl, we would have had a heroin epidemic. What's the evidence for that? The Mexican cartels took over technology from the Colombian cartels. They started to follow their recipe on heroin. They started to gain turf in the Midwest and the Northeast. They started bringing in this new product, which was already causing overdoses all by itself. The Colombian chemical manufacturer, the purity is about, I don't know, let's just say it's double what the Mexican black tar, the traditional Mexican heroin was like. I think things happened so quickly that they took out an experiment they did in 2006, where they brought fentanyl in to see whether it was likable, and it caused a lot of deaths. And the DEA went and found the lab and say again.
They had to get hold of the ingredients.
I have no idea. I have no idea how the Mexican cartels work with the Chinese manufacturers. But we also, so the other parts of the theory, so now we're bringing some of the other voices from the drug policy community, will say China has huge industrial capacity and a poor regulatory system, right? Just look at their pollution problem. And they're trying to get a control of their pollution problem, but they don't have as weak as our EPA is, they don't have as powerful an EPA as our EPA, right? And so it's a poor regulatory environment. So, and fentanyl is such a low volume drug that it's easy to produce at low volume, have a big customer base based on that kilo, and it's easy to transport that kilo across the Pacific Ocean because we have several million tons of goods that come over from China in a given year. so easy to hide. The problem with their argument, and I would say it to their faces, is that, okay, fentanyl is so profitable and Chinese manufacturing and deregulation is such a powerful force. Why not Australia? Why not Europe? Why not other places that China trades with? Why hasn't fentanyl gone international? It hasn't. And it hasn't because it's only gone to the 2 countries that had the triple wave, pills to heroin to fentanyl. Those 2 countries are us and our neighbor to the north, right? So I think it's political economy, not pure economy. Thank you. Question?
I'm going to run around. While I run across the room, we have one online from Joe Fineglass who asks, how much does an underlying pain epidemic give rise to increase in opioid use?
Well, I think that's already been established. I'm not a researcher in that realm, but there's quite a bit of literature showing that there were good reasons, good fomenting reasons behind wave 1, and one of those was a pain crisis. Americans through obesity or through lifestyle, through poverty, we are ranked pretty darn high in our pain scores when compared to other countries. And so there was a reason for, I still think the lawsuits are all blaming, probably as they should, the pharmaceutical industry, the wholesalers and how they distributed and turned a blind eye to 1 billion pills going to West Virginia, for example. But at the same time, there was still an underlying demand for that. And that demand hasn't gone away. Still a lot of people in pain that need pain control. So we're in that classic unfortunate position of rock and hard place, right? Whereas damned if we do and damned if we don't. But we do need to address people's suffering. Buprenorphine could be an answer. It's both a medication to treat opioid addiction, but it also has it's kappa antagonist and it's a powerful pain reliever. And so buprenorphine is one possible answer. Thank you for the question.
Do you have any predictions or data about what happens when xylazine is smoked? Because you have like the trend of xylazine from the east and smoke.
I love that question. Thank you. No, but I'll guarantee that it's different, right? So what's that? Different than injecting it. And it's purely speculative at this point, right? The problem with xylazine is that it's an animal drug, not a human drug. And so we know nothing about it. We say, oh, it's similar to clonidine, which is a human drug, and it is. And hopefully that remains true because we can use the clonidine model to help us understand it. But it's a powerful vasoconstrictor, which means that it's going to cause its damage. I'm focused on the wounds. I'm not really focused on overdose per se. And I think the overdose question is a separate and interesting one about whether a double downer will lead to more overdoses or whether xylazine, because it's a weaker downer, to the degree that it substitutes for the fentanyl on a population level, might actually lead to lower overdose. Did I say that right? Yeah. Double downer might lead to a higher overdose. So I don't know the overdose question. But the smoking question, I think if I were to take a peripheral vasoconstrictor, it's going to cause more damage if I inject it locally. It's going to cause more local damage if I inject it locally than the distal effect. The bloodstream dilutes stuff, right? The lungs are going to dilute it. They're going to send it to all parts of the body. It's hard to imagine getting a wound down here because you smoked. Now, that said, I'm open to surprises because it is a new drug and we, expect the unpredictable at this point. I'm hoping that it's safer to smoke. We do have xylazine on the West Coast. It's not very common yet. Nobody has wounds. The ER docs send me photos and say, look, we got a xylazine wound. I said, that person's been tell me I'm wrong. Tell me that person hasn't been injecting heroin and fentanyl, prior to smoking, for 15 years. And they say, oh yeah. Yeah. And then they do a urine test or something and find that there's no xylazine. So people want to see the wounds, but they're not happening at least in the Western, but we don't have a lot of xylazine yet and people are smoking everything. Stay tuned.
Following up on the previous question about like, the role of like the drivers of the prescription opioid crisis, as you said, like probably like one of the core drivers of the whole thing. What do you think about the role of physicians? And I'm asking particularly because like you mentioned, oh, now people blame the manufacturers and distributors, but of course, like it's like, the prescription all has like a signature of the physicians on it, and they should really know, right? They're the gatekeepers, the highly paid gatekeepers to protect the patients. And I think it's also something that is continuing to be a problem. So, I have undergrads, undergrads who tell me that they have friends who became addicted because of, the physicians like prescribed something after they had a sports injury or something. It's really something that continues to be very different from Germany, and like physicians there, like it's a very, very different way physicians handle opioids.
So what's been documented, and I buy it, I accept it, is that doctors in America were relatively conservative. Some people would even say opioid phobic for a generation or two, or maybe multiple generations, depending on how far back we want to go. And then their practices liberalized because there were studies that were reassuring. There were official policy statements and medical society statements that say, we're under-treating pain. We need to treat pain better. So I think that was a liberalizing effect. And from an economics point of view, anytime you deregulate or liberalize, whether, liberalization is happening on an economic level or happening on a cultural level, I think both happened, right? But I'm also, so then of course, it's been well documented that industry influences doctors' practices. It's a capitalist society. Pharma can do what it wants, and it has very powerful incentives to guide doctors on what to do. But on the other hand, doctors are also responding to demand, right? They're also finding themselves caught in a position where it was hard. And I'm not making excuses here. I'm just saying, I'm just laying it out ecumenically, right? That they found it hard to say no to a patient, right? Now, I think we could divide our policy between the acute prescription, knee injury, versus the chronic prescription, right? We really need to clamp down on the acute prescription, right? People can take care of their knee problems with, acetaminophen or 3 days of a drug instead of, 30 days. Chronic is a conundrum. Chronic is a conundrum because we have people that are screaming, right? And they feel abandoned and misused, abandoned by that. And that's a no-no in medicine. We don't abandon our patients, right? And so we did abandon them. A lot of people went to heroin, right? What would we rather have? People into care or out on the streets getting their opioids? I say bring them into care. So conundrum, right? Complexity, it's modernity, right? We just have to deal with complexity.
We have time for one more. We just run over.
We can squeeze in two.
You mentioned there being this fifth wave that you're seeing emerging.
Again,
You mentioned that you've seen this fifth wave that's starting
Yeah,
to
yeah.
emerge. Are you able to share anything about that and anything that we can be doing to perhaps act in a preventative way?
So people are getting super tolerant to the fentanyl, right? Potencies, purities are going up. They're going up in ways, the amount that people are consuming and the purity of the product they're consuming is mind-boggling from a clinical perspective. It's hard to wrap our hands around people using 50 to 100 milligrams of pure fentanyl a day. And I can give you the equation if you want, how I got there. But we just got a paper published that has a little back of the napkin calculation like that. So what's happening in the fifth wave, and it's a little presumptuous to call it a fifth wave now, so I'm thinking of it as sort of fentanyl plus combinations, is that there's a lot of polysubstance use where fentanyl is at the center and there's an additional drug. And sometimes that drug is unintentionally co-used, it's an adulterant, and sometimes it's intentionally. So the examples are methamphetamine and fentanyl, xylazine and fentanyl, and atezolame and other designer benzos and fentanyl. And then you've got the wild card of pills, which are, you know, kitchen sink of fentanyl plus. So that's what I'm problematizing right now.
Probably a really big question, but what is the public, like a good public health approach? There's been so many kind of being, I think, teased out now at like larger health systems, but what are some ones that you've seen have worked to get people maybe into treatment and to prevent maybe just use of these new combination drugs, maybe in people that aren't patients that had to, you know, go to those drugs from being prescribed opioids, you know, like on the street, people that are getting into these situations? What are, you know, some approaches, public health approaches that you've seen that are promising?
I mean, so it is a good question, and it is a big question. And if it had a straightforward answer, we would have found it already, and we would have put a bigger damper on this fentanyl epidemic thus far. Fentanyl confounds us. It's doing stuff that a drug that's that unlikable and that potent shouldn't have lasted this long. The reason why it's not burning out is because the denominator is huge, right? That if you start with 2.5 million users and you lose, unfortunately, 70,000 a year, you know, just on the opioid side of things, that's many years. That's 20 years before death alone is the solution. And I don't mean to be overly, you know, cynical, but starting with that, it's confounded everything we've thrown at it. You know, deregulation of buprenorphine, massive rollout of naloxone across the country, new combinations coming in, new potent drugs that we don't understand, like xylazine. What I'm worried about is that the compassionate approach models, harm reduction, inviting people into care, lowering barriers, are being outweighed by criminal justice models now, where bad drugs, bad people, discipline, re-stigmatizing, that's all going to be, I'll put more than a nickel down. I'll put quite a large sum down. That's going to be counterproductive, right? San Francisco's doing it, Portland's doing it. It's going to be counterproductive. We know what works. You know, bring back people into the regulated drug supply, meaning if you're a chronic pain patient, get to a pain doctor. We know treatment works by any means necessary. Incentivize it, right? We have a bunch of economists here, right? Let's work on incentive models, you know, behavioral incentive models, financial incentive models. That'll bring people into care. Incentivize contingency management, right? What is that? That's a financial incentive model. You know, increasing payments over time. That'll be people into care and retain them in care. Not everybody, but enough of the population that it starts to put a fire extinguisher on the epidemic. But I'm always going to argue for harm reduction because it recruits people. It's a high engagement model. And one big thing that I would suggest there is to end the siloization of harm reduction here, not trusting the larger society, working together with treatment, right? Treatment is harm reduction, right? Just make a continuum, you know? Where are you? Oh, you entered treatment and you left after a month. Well, great to see you back in the harm reduction program. Oh, you ready for treatment again? You know, fluidity, peer navigation, incentives. That's the best I got.